Chapter 8: Dysrhythmia Interpretation and Management. Dysrhythmia interpretation is a fundamental skill of critical care nurses, and it's crucial for both the early nursing and medical intervention. Electrocardiography is the process of creating a visual tracing of the electrical activity of the cells within the heart. And that is what you are seeing on that EKG tracing. That is the electrical activity as it passes through the heart, beginning at the SA node. The interpretation of cardiac rhythm disturbances, or dysrhythmias, is an essential skill, and the ability to rapidly analyze that rhythm disturbance, as well as to initiate appropriate treatments, both improves patient safety and optimizes successful outcomes. The critical care nurse is often the healthcare professional responsible for the continuous monitoring of the patient's cardiac rhythm and has the opportunity to provide the intervention that can prevent an adverse clinical situation. When all things cardiac, it is always good to catch and intervene early. In reviewing cardiac physiology, the electrocardiogram detects a summation of electrical signals generated by specialized cells of the heart called pacemaker cells. These pacemaker cells have the property of automaticity, meaning these cells can generate a stimulus or an action potential without any outside stimulation. The electrical signal is conducted through specialized fibers of the conduction, and this coordinated electrical activity, followed by a synchronous mechanical event, constitutes the cardiac cycle. It keeps all those chambers of the heart, the atria, which contract first, giving that delay at the AV node, and finally followed by ventricular contraction. As we said, this electrical signal is conducted through specialized fibers of the conduction system and leads to the mechanical or muscle cells of the heart, where that cardiac contraction actually occurs and is generated. Thus, there must be an electrical signal for this mechanical event or contraction to occur. The coordinated electrical activity, followed by a synchronous mechanical event, constitutes the cardiac cycle itself. There are two phases of electrical activity: the depolarization or active phase, where contraction occurs, or repolarization phase, resting, when there is no action occurring. And this is correlated with the two mechanical responses: systole, contraction, or diastole, relaxation. Both phases, depolarization and repolarization, are equally important. Depolarization, obviously, because it is that contraction which pumps the blood, gets the blood moving and perfusing through the body. Whereas repolarization, that relaxation, this is where the heart chambers have that opportunity to refill with blood before the next contraction or depolarization. Cardiac muscle cells generate an electrical current called a cardiac action potential. And the primary pacemaker of the heart, where it should originate, is the sinoatrial node or SA node, located at the top of the atria. And the response generated by either by the pacemaker or muscle cells once stimulated is called the action potential. The cardiac action potential consists of phases, all related to that depolarization, repolarization, and the resting or polarized state of the cells themselves. This contraction cycle is heavily based on electrolytes. During depolarization, the sodium outside of the cell rushes in, while potassium that is inside of the cell rushes out. This causes the contraction itself. And then as we move forward to repolarization, the sodium rushes back out and the potassium rushes back in, so that the cycle can reset and begin again. The stimulation of cardiac muscle cell by an electrical impulse changes the permeability of the myocardial cell membrane. The sodium ions rush into the cell via sodium channels within the cell membrane, and the potassium ions flow out of the cell, resulting in a more positively charged cell interior, resulting in that depolarization. Let's talk about the cardiac conduction pathways. As we said, cardiac conduction begins at that SA node, which is where the original pacemaker initiation of the cells begins. The electrical signal stimulates the atria muscle, called the atrial systole, and causes the atria to contract simultaneously and inject their blood volume down into the ventricles. This step is called the atrial kick, and it contributes approximately 30% more blood to the cardiac output of the ventricles. From here, the impulse quickly reaches the arterioventricular node, or AV node, located in the area called the AV junction. And this is just in between the atria and the ventricles, and provides that slow pause to allow the heart to reset and get ready for ventricular contraction. The AV node also has a pacemaker of its own and can discharge an impulse if the SA node should fail. The electrical impulse is then rapidly conducted through the bundle of His to the ventricles via the left and right bundle branches. The left bundle branch further divides into the left anterior fasciculi and the left posterior. The bundle branches divide into smaller and smaller branches, finally terminating in tiny fibers called Purkinje fibers that reach the myocardial muscle cells or monocytes. The bundle of His, the right and left bundle branches, and the Purkinje fibers are also known as the His-Purkinje system. These nodes have their own inherent rates. Our primary pacemaker of the heart, that SA node, has an inherent rate of 60 to 100 beats, which is also a normal heart rate. Should that fail, we do have the backup of that AV node, which goes at an inherent rate of 40 to 60 beats per minute. Should both the SA node and AV node have failed, the ventricles and Purkinje fibers do have their own final fallback inherent rate of 20 to 40 beats. A dysrhythmia, this is what occurs when that automaticity of the normal pacemaker cells of the heart is either stimulated or suppressed. Cardiac monitoring, a 12 lead ECG. The first ECG of the human heart was recorded in 1887 by British physiologist Augustus Waller. The PQRST complex, P wave, QRS complex, T wave, was later described by William Einthoven. Einthoven won the Nobel Prize in Medicine for inventing the electrocardiograph, just like we're still doing today. And it provides a way to monitor those electrical impulses as they move through the heart. It gives us a very clear image of exactly what is occurring. In cardiac monitoring, electrodes are applied to the skin to transmit the electrical signals of the cardiac impulses through the conduction system. The signal is then amplified by ECG monitor to a digital display. There's going to be many things we need to be aware of, though. Before application, check the electrodes. Ensure that the gel is moist. Attach the electrode to the lead wire and place it in the designated locations. Unless it's very old, your ECG will have a diagram of where it wants those electrodes to be placed. Following electrode placement, assess the signal to ensure the waveform is clear and not disrupted by artifact. And at the beginning of each shift, assess that the electrodes are in place and in the correct anatomical position. Unfortunately, these things will fall off in the night, and we'll begin to start getting strange rhythms on the screen. And you always have to assess that very quickly, even though, yeah, it could just be a case where the guy had a lot of chest hair. You want to clip the chest hair. You want a good, smooth, you want a nice, clean surface. Cleanse the skin with mild soap and water. Assess that electrode gel. Change the electrodes if necessary. We're going to do everything we can to get as clear of a picture as possible. Within the leads, there are 3 standard limb leads, 3 augmented limb leads, and 6 precordial leads. And these impulses towards the electrode with a positive QRS complex, and impulses away from the electrode with a negative QRS complex. The 12 lead ECG provides a view of the electrical activity of the heart from 12 different views or angles, both frontally as well as horizontally. In lead 1, this records the magnitude and direction of current flow between the negative lead on the right arm and the positive lead on the left arm. In lead 2, this records activity between the negative lead in the right arm and the positive lead on the left leg. And in lead 3, this records activity from the negative lead on the left arm to the positive lead on the left leg. On the other hand, the augmented limb leads provide a unipolar, meaning they record electrical flow in only one direction. A reference point is established within the ECG machine, and the electrical flow is recorded from that reference point towards the right arm, the left arm, and the left foot. The 3 lead monitoring system depicts only the standard limb leads. These leads are marked as right RA, LA, and left leg. The right arm and left arm leads are placed just below the right and left clavicle, and the left leg lead is placed in the left abdominal area. In most settings, a 6-second strip is the standard of the patient's rhythm, and it's obtained and documented in the patient chart at intervals from every 4 hours to 8 hours, based on the patient acuity level and institutional policy. In addition to scheduled times, a rhythm strip is documented anytime there's a change in rhythm. The ECG paper contains a standardized grid where the horizontal axis measures time and the vertical axis measures voltage and amplitude. The larger boxes are circumscribed by darker lines, while the smaller boxes by lighter lines. The larger boxes contain 5 smaller boxes of the horizontal line and 5 on the vertical, for a total of 25 per large box. Horizontally, the smaller boxes denote 0.04 seconds. The larger box contains 5 smaller boxes and therefore is equal to zero point 0.2 seconds. Along the uppermost aspect of the ECG paper are vertical hash marks that occur every 15 large boxes. The area between these marks equals 3 seconds, and some ECG paper even has markings every 1 second. The normal ECG tracing is composed of a P wave, a QRS complex, and T waves. These waveforms rise from the flat baseline, called an isoelectric line. The first thing you want to assess is the P wave. The P wave represents atrial depolarization, and normally a P wave indicates that the SA node initiated the impulse that depolarized that atrium, because that is what you are seeing with that first P wave there on the left. However, a change in the shape of the P wave may indicate that the impulse rose from a site in the atria other than the SA node, and we'll get into that further when we start talking dysrhythmias. Next, we have the QRS complex, and this represents that ventricular depolarization. The classic QRS complex begins with a negative or downward deflection immediately after the PR interval. The first negative deflection after the P wave is called the Q wave, and a Q wave may or not be present before the R wave. Here we've just got a diagram showing the different manifestations these QRS complexes can take. One thing to be aware of with that Q wave is that a pathological Q wave that has a width of 0.04 seconds or greater and a depth that is greater than 1/4 of the R wave amplitude. A pathological Q wave are found on ECGs of individuals who have had a myocardial infarction, and they represent that myocardial muscle death. Especially when we start getting into heart blocks here later in this chapter, we're going to start talking closely on the PR interval. And the interval is the beginning of the P wave to the next deflection of the baseline, which is called that PR interval or PRI. The PR interval measures the time it takes for the impulse to depolarize the atria and travel to finally reaching that AV node and dwell there with that brief pause we talked about. On the other hand, the QRS interval is measured from where it leaves the isometric line of that PRI to the end of the QRS complex. And you can see we've got that mapped out here on our diagram as well. The waveform indicates the QRS complex, whether it has a Q wave or an R wave, marks the beginning of the interval. The normal width of the QRS complex is 0.06 to zero point 0.1 seconds. This width equals 1.5 to 2.5 small boxes. A QRS with a width greater than zero point 0.1 may signify a delay in the conduction through the ventricles due to a variety of factors, everything from myocardial infarction to atherosclerosis and aging of the conduction system, or even cardiomyopathies. Next, after that QRS complex, we have that ST segment there shaded in on our diagram. The ST segment connects the QRS complex to the T wave, and it's usually a isoelectric or flat. However, in some conditions, the segment may be depressed, falling below that baseline, or elevated, rising above that baseline. The point at which the QRS complex ends and the ST segment begins is called the J junction point. ST segment change is measured at 0.04 seconds after that J point. To identify ST segment elevation, use the isoelectric portion of the PR segment as a reference for what is baseline. Next, note whether the ST segment is level with the PR segment, or is there a displacement in the ST segment that can indicate myocardial ischemia or injury. Next, we have the T wave. The T wave represents ventricular repolarization or relaxation. Changes in T wave amplitude or direction can indicate electrical disturbances resulting from an electrolyte imbalance or myocardial ischemia or even injury. For example, hyperkalemia can cause tall peaked T waves, and ischemia may cause an inverted or upside down T wave. Another area we may measure is the QT interval. The QT interval is measured from the beginning of the QRS complex to the end of the T wave, and this interval measures the total time taken for ventricular depolarization and repolarization. Abnormally prolonging the QT interval increases vulnerability to lethal dysrhythmias, such as ventricular tachycardia or VFib. Normally, the QT interval becomes longer with a slower heart rates and shortens with faster heart rates, thus requiring a correction of this value. Generally speaking, the QT interval is less than half the RR interval. The final waveform we're going to talk about is known as the U wave. And this waveform follows the T wave, and it represents repolarization of a small segment of the ventricles. The U wave is usually small, rounded, and less than 2 millimeters in height. Larger U waves may be present in patients with hypokalemia, cardiomyopathies, or digoxin toxicity. When interpreting a rhythm, use a systematic approach. First, look at your rate, your heart rate, including both your ventricular and atrial rates. Then you want to identify the regularity of the rhythm, meaning does it occur at regular, evenly spaced intervals? Measuring the PR intervals, QRS complexes, and QT complexes, as well as looking at the shape of the waveforms and their consistency. Identify any underlying rhythm as well as dysrhythmias, and most importantly, assessing the patient's tolerance of the rhythm or any symptoms that are occurring. When identifying the rhythmicity, you want to look at the regularity or pattern of the heartbeats. And it's assessed using things like electronic or physical calipers, or even a piece of paper and a pencil. By that, you take just a blank plain piece of paper and put it over top of that 6 second strip, and put a hash mark right at the top of each QRS complex. From there, you could slide that hash mark along and make sure that it's an easy way to measure that each QRS complex is occurring at a very precise, regular interval. When calculating heart rate, one easy method is going to be the 6 second method. And that if you look at that, at our strip there between those two red hash marks is 6 seconds. And you would just count the QRS complexes, in this case, one, two, three, four, five, six, and multiply that by 10. And you know that this patient's heart rate is roughly 60 beats per minute. Keep in mind that that 6 second method is only effective if it is a regular rhythm. In the case of an irregular rhythm, you could have wildly different numbers based on each 6 second strip. In the case of these irregular rhythms, you're going to need a much larger sample, such as a 15 or even 30 second strip. In the case of a 30 second strip, you would count the beats for 30 seconds and then multiply it by 2, giving you a much more accurate measurement. When looking at waveform configuration, keep in mind that all waveforms should look alike in a normal ECG. Abnormal shapes may indicate that the stimulus was caused by a waveform such as an ectopic focus, or that there is a delay or block in the conduction, creating a bundle branch block. It's also important to confirm that a P wave precedes each QRS complex, and that a T wave follows each QRS complex. Next, we want to identify and measure each interval, beginning with the PR interval, represented by that orange block there at the bottom left. And that PR interval is measured by the beginning of the P wave to the beginning of the Q wave. For the QRS complex, that's going to be represented by that pink block at the top. And it's going to be measured from the start of the Q wave to the end of the S wave. And finally, the QT interval, which is measured from the beginning of the Q wave to the end of the T wave and represented by that blue block on the bottom right. The basic dysrhythmias are classified on their site of origin, including the SA node at the top left, the atria, a V node or junctional rhythms, or even a ventricular rhythm. Looking at our rhythms, let's begin with a normal sinus rhythm. This is going to reflect normal conduction of the sinus impulse through the atria and ventricles, and also any deviation from that sinus rhythm is a dysrhythmia. Thus, it's critical to remember this is your baseline, and it's always going to have a regular rhythm, a rate of 60 to 100 beats per minute, a normal P wave in the lead 2, a P wave that precedes each QRS complex, and normal aspects of both our PR complexes, QRS complexes, and QT intervals. For our first dysrhythmia, it's going to be sinus tachycardia. When you see the term sinus, this is a rhythm originating in that sinoatrial node. In this case, it's going to have a rate. It's going to be a normal sinus rhythm in all aspects, except it has that rate of 100 to 150 beats a minute. These could have a lot of causes, everything from hyperthyroidism to hypovolemia, heart failure, anemia, exercise, use of stimulants, fever, or any sympathetic response, such as a case of fear, pain, or anxiety. On the other hand, sinus brady is going to be a sinus rhythm originating in that sinoatrial node that is occurring at less than 60 beats a minute. And it could have everything from vasovagal stimulation, drugs, ischemia, diseases of the nodes, increased intracranial pressure, hypoxemia, and in the case of athletes, it may even be normal. And that distance runners, really extreme athletes, could have a normal bradycardia as their normal everyday baseline. Quick quiz. What symptoms should be anticipated in a patient with decreased coronary artery perfusion? That be A, cyanosis, B, chest pain, C, dysrhythmia, or D, low urine output? And that answer is going to be B, chest pain. What should include you in there was the decreased perfusion to the coronary arteries. In this case, our patients having possibly angina or even an MI from a blockage. For our case study, a patient is admitted with an acute MI. The nurse notes that his cardiac rhythm has changed from normal sinus rhythm to bradycardia with a rate of 45. What symptoms would indicate the patient is not tolerating the low heart rate? That could be cool, clammy skin, decreased perfusion, hypotension. For our clinical judgment, explain prolonged tachycardia may lead to heart failure. In this case, the fast heart rhythm may cause a decrease in cardiac output because of the shorter filling time of the ventricles. When the heart begins beating so fast, it's still beating, but it doesn't have time to fill with blood. That preload can be very important to cardiac output, and the shorter filling times may lead to coronary artery perfusion and even ischemia. In the case of sinus arrhythmia, this is still a sinus rhythm, though the rate varies with respirations, could increase with inspiration and decrease with expiration. It rarely affects hemodynamic status, but it does cause that irregular rhythm, though while measuring each QRS complex, each may look perfectly normal because it is originating in the sinoatrial node, the sinus. We've got that normal P wave followed by a normal looking QRS and T wave, though in this case they're occurring at irregular intervals based on the patient's breathing. Moving on to sinus arrest or exit block. This is a failure of the SA node to generate an impulse, and it's called a sinus arrest. The pause results from a lack of stimulus in the SA node. This sinus beat following the pause is not on time because the SA node has been reset, and the next sinus impulse begins a new rhythm. The end result is there's no atrial or ventricular depolarization occurs for one heartbeat or more. On the other hand, a sinus exit block also results in a pause, but the P wave following the pause in the rhythm is on time or regular because the SA node doesn't reset. This sinus impulse simply fails to exit the SA node. As we've discussed, the SA node is the dominant pacemaker of the heart that initiates the heart rhythm. However, cells outside of the SA node, though still within the atria, can create an ectopic focus, meaning that SA node, that primary pacemaker, is not keeping control of the heart. We now have erratic cells within that atria sending out their own signals that are triggering heart rates. And in this case, we're getting those odd PR intervals. In the case of AFib up here, you notice that it's irregular with its QRS complexes, but there's no P wave. It's just sort of squiggly lines before each QRS complex. Moving down to atrial flutter, on the other hand, that's going to cause those big shark tooths like P waves that have irregular QRS complexes occurring in between it. The reason that's occurring is in the case of AFib, they're not getting the signal for a contraction. So the atria are just sort of quivering on top while the QRS, the ventricles, are still contracting. In the case of A flutter, the atria are opening and slamming shut while the QRS is occurring with a junctional or slower rhythm. These atrial dysrhythmias can have different causes, everything from stress and electrolyte imbalances to hypoxia or atrial injury. It may also be due to digitalis toxicity, hypothermia, hyperthyroidism, alcohol or pericarditis. Another atrial dysrhythmia you may see is a premature atrial contraction. And you're going to see that down there in our diagram. A premature atrial contraction is a single ectopic beat arising from the atrial tissue, but not the SA node. So the patient will have a normal sinus rhythm, but then it'll get an ectopic signal from one of its ectopic cells, an irregular cell up in the atria, that causes just an abnormal atrial beat that's completely out of rhythm with the normal sinus rhythm we're seeing occurring. If the ventricles respond to every ectopic atrial impulse, it's called a one-to-one conduction, whereas there's one P wave for each QRS complex. Because those P waves arise outside the sinus node, the shape is different from our normal sinus P waves. Another term you may hear is a wandering atrial pacemaker. And this is a dysrhythmia characterized by at least three different ectopic atrial foci, followed by a QRS complex at a rate less than 100 beats per minute. It also has at least three different P wave shapes that are noted. The P waves are wandering atrial pacemaker can be upright, inverted, flat, pointed, notched, or slanted. On the other hand, a multifocal atrial tachycardia is essentially the same as a wandering atrial pacemaker, except the heart rate now exceeds 100 beats per minute. Again, it has at least three ectopic P waves that are noted, meaning there's three differently shaped P waves within it. And the dysrhythmia is almost exclusively found in a patient with COPD. Pulmonary hypertension occurs and results in an increased atrial pressure and dilation that creates that irritable atrial signals. You started to touch on atrial flutter a little earlier, and as soon as you see those sawtooth, shark tooth patterns in between each QRS, you should really be cueing in on atrial flutter. This condition arises from a single irritable focus in the atria, and the atria fires at an extremely rapid, regular rate between 240 and 320 beats per minute. The P waves are called flutter waves and may have a sawtooth pattern, that shark tooth pattern. It's going to be very pointed, peaked P waves. And the ventricular response may be regular or irregular based on how many flutter waves are conducted through that AV node. The number of flutter waves to each QRS complex is called the conduction ratio. The conduction ratio may remain the same, or it could vary depending on the number of flutter waves that are conducted in the ventricles. The description of atrial flutter might be constant at 2 to 1, 3 to 1, 4 to 1, or it may even vary between each beat. When looking at atrial fibrillation, you'll notice the erratic impulses that are occurring in between each QRS complex, and that it's more like a squiggly line in between each QRS ventricular contraction. And this is because of the multiple ectopic foci of the atria that causes a chaotic quivering of the atria and eventual ineffectual contraction, and that the atria is not contracting, it's more just quivering on top. In this case, the AV node is bombarded with hundreds of atrial impulses and conducts these impulses in an unpredictable manner to the ventricles. This irregularity is actually called irregularly irregular. One complication of this is the thromboembolism forming, in which case the blood in the atria is not being contracted down to the ventricles. It's just sort of filling and quivering, which causes a clot to form on top. In our case study, a patient comes to the emergency department complaining of headache, numbness of his left arm and hand, and slurred speech. The pulse is 120 beats per minute and irregular. The blood pressure is 136 over 88. What is the probable cause for this symptoms? And just as we discussed with the AFib, and that clot is forming in the atria. The major danger is that this clot will become dislodged and begin to be perfused to the body, landing in the heart in the form of an MI, in the lungs in the form of a PE, or in this case, that clot is lodged in the brain in the form of a stroke. When dealing with dysrhythmias from the AV junction or AV node, these are also called junctional rhythms. In this case, because of the location of the AV node in the center of the heart, these impulses may be generated moving forwards towards the ventricles, backwards towards the atria, or both. And this is the reason for the three different P wave waveforms that may be associated with junctional rhythms. When the AV node moves impulses forward, P waves may be absent as the impulses enter the ventricle first. When depolarization occurs backwards, an inverted or upside down P wave is created. Once the atria have been depolarized, the impulse then moves forward down the bundle of His and depolarizes both ventricles normally. When the impulse is conducted both forward and backward, P waves may be present after the QRS complex. In this type of conduction, the impulse first moves into the ventricles, depolarizing them and creating the QRS complex. But because that impulse is also being conducted backwards, some atrial depolarization occurs and a late P wave is noted after the QRS. Although we have three different junctional rhythms that may be seen, the first would be just known as a junctional rhythm. And you'll notice in that top strip how there is an absent P wave with a heart rate ranging between 40 and 60 beats per minute. In the case of an accelerated junctional rhythm, you'll again notice an upside down P wave with a heart rate that is 60 to 100 beats per minute. And finally, in junctional tachycardia, this maintains the characteristics of other junctional rhythms, though has a heart rate of over 100 beats per minute. This basic junctional rhythm may also be known as a junctional escape rhythm. Because the SA node is the primary pacemaker of the heart, when that SA node fails and is not sending out impulses, the junctional rhythm, the AV node, will begin sending out signals of its own as an escape, as a fallback. And this is the reason for its lower heart rate of 40 to 60 beats per minute. It also may result in possibly decreased cardiac output. So, as with all dysrhythmias, make sure to assess your patient closely. In the case of accelerated junctional rhythm and junctional tachycardia, it will again have all the hallmarks of a junctional rhythm in those P wave changes, whether they're absent or inverted. An accelerated junctional rhythm has a rate between 60 and 100 beats per minute, while the rate for junctional tachycardia is greater than 100 beats per minute. In the case of a premature junctional contraction, just like the premature atrial contractions we previously discussed, this is results from irritable areas in the AV node and junctional tissue that can generate a premature beat that are earlier than the next expected beat, meaning you may have the regular underlying rhythm with a junctional beat occurring out of step in the middle of it. These premature beats are similar to PACs, but they have the characteristics of a junctional beat. The regularity of the underlying rhythm is interrupted by this premature contraction. Next, let's talk about paroxysmal supraventricular tachycardia. This occurs above the ventricles and it has an abrupt onset and cessation. It's initiated either by a premature atrial contraction or a premature junctional contraction. And in this case, an abnormal conduction pathway through the AV node or accessory pathway around the AV node results in the extreme tachycardia. The QRS complex is typically narrow, and a P wave may or may not be present. The primary criteria are those of the abrupt onset and cessation of the dysrhythmia. This often occurs in healthy young adults without structural heart disease. It may be precipitated by an increase in catecholamines, stimulants, heart disease, electrolyte imbalances, or even an anatomical abnormality. Moving on to ventricular dysrhythmias, these arise from ectopic foci within the ventricles. Because of the stimulus that depolarizes the ventricles in a slower, abnormal way, the QRS complex appears wider and has a bizarre shape. The QRS complex is wider than 0.12 seconds and often wider than 0.16 seconds. The polarity of the T wave is opposite that of the QRS complex, and the depolarization from abnormal ventricular beats rarely activates the atria in a retrograde fashion. Therefore, most ventricular dysrhythmias have no apparent P waves. However, if a P wave is present, it is usually seen in the T wave of the following beat, or it has no relationship at all to the QRS complex, and is dissociated from the ventricular rhythm. Ventricular dysrhythmias can be life threatening, thus, fast recognition and intervention are imperative. Some common causes of ventricular dysrhythmias are hypoxemia, where low myocardial ischemia, injury, or infarction, heart disease, hypokalemia, hypomagnesemia, acid base imbalances, or increased catecholamine levels. Quick quiz. When two PVCs occur in a row, this is known as A, bigeminy, B, a couplet, C, multifocal, or D, ventricular tachycardia. And that answer is going to be B, a couplet. And as you can see in our diagram there on the left, a couplet are two premature beats in a row, whereas bigeminy would be that premature beat occurring at every other. A trigeminy would be occurring at every third, and a quadrigeminy occurring at every fourth. Premature ventricular contractions are a common ventricular dysrhythmia. The PVCs are early beats that interrupt the underlying rhythm, and they can arise from a single ectopic focus or from multiple focuses within the ventricles. They appear as wide and bizarre beats, have a compensatory pause afterwards, and the patterns are again bigeminy or trigeminy if they occur at every other beat or every third beat, or couplets if those PVCs occur back to back, or even triplets if they occur three in a row. Assess and treat the underlying cause of these premature ventricular contractions. Everything from hypoxemia, ischemia, or electrolyte imbalances should be suspected. The patient may also need ventricular antidysrhythmic agents such as amiodarone. Why are multifocal PVCs considered more dangerous than unifocal PVCs? Multifocal PVCs indicate multiple areas of irritable cardiac tissue, which places the patient at a much greater risk for ectopy. The PVCs may occur in healthy individuals and usually do not require treatment. The nurse must determine if the PVCs are increasing in number by evaluating the trend and assessing the patient for symptoms and hemodynamic status. If PVCs are increasing in frequency, the nurse should evaluate for potential causes. What makes a PVC so much more dangerous than a PAC or even a PJC? They're going to be frequent, multifocal, possibly two in a row, and the danger of R on T, where a QRS complex could fall onto a T wave and throw the patient into a life-threatening, dangerous dysrhythmia that throws the rhythm of the heart completely out of whack. Here we have a representation of that R on T resulting in ventricular fibrillation or VFib. You see, it begins with the sinus beats, where that PVC falls on a T wave and then sends the patient's heart into a chaotic rhythm, that ventricular fibrillation. Of your life threatening ventricular dysrhythmias, the first is going to be ventricular tachycardia. This is a rapid, life threatening dysrhythmia originating from a single ectopic focus in the ventricles. It's characterized by at least three PVCs in a row, known as a run. And the ventricular tachycardia occurs at a rate greater than 100 beats per minute, but the rate is usually around 150 and maybe upwards of 250 beats per minute. Depolarization of the ventricles is abnormal and produces that wide V shaped QRS complex. The patient may or may not have a pulse, and that's going to be critical to assess for, as pulseless ventricular tachycardia is one of your shockable rhythms. VTAC is characterized by the wide QRS complex, greater than zero point 0.1 seconds. Usually regular, though it may or may not have a pulse. And again, treat that pulseless the same as VFib. It has a significant loss of cardiac output and may result in serious hypotension as well. Another phenomenon within VTAC you may have heard of is torsades de pointes. And this is a type of ventricular tachycardia that's caused by a prolonged QT interval. Unlike normal VTAC, where the QRS complex waveforms have similar shapes, torsades de pointes is characterized by the presence of both positive and negative complexes that move above and below the isoelectric line. This lethal dysrhythmia is treated as a pulseless VTAC. Magnesium deficiency is often a cause of this. The dysrhythmia can often be prevented by routine measurement of the QT/QTC intervals, especially if the patient is receiving drugs that prolong that QT interval. Increases in these intervals are reported to the provider. Potential drug related causes are explored, and magnesium levels are monitored and corrected closely. On the other hand, ventricular fibrillation is a chaotic rhythm characterized by a quivering of the ventricles, just like with atrial fibrillation, which results in a total loss of cardiac output and pulse. This is a life threatening emergency, and is the more immediate the treatment, the better the chances of survival will be. Again, there's going to be no discernible P, Q, R, S, or T waves, just like in our example below, where it is coarse versus very fine, zero cardiac output, and it requires emergent defibrillation. The nurse is talking with the patient. Suddenly, the nurse looks up at the monitor and sees a ventricular tachycardia pattern. What are your priority interventions going to be? Because a loose lead or electrical interference can produce this waveform, it's immediately assess the patient for a pulse and consciousness. From there, check our leads. If this is not the problem, evaluate the patient further, calling for help. The patient can be in stable ventricular tachycardia before decompensating, though this is a life threatening emergency that should be taken seriously. Just like with our junctional escape rhythm, there's also a ventricular escape rhythm. These escape ventricular rhythms originate from the Purkinje fibers and have a rate of 25 to 40 beats per minute. The rhythm may be regular, though it'll have wide QRS complexes and no P waves. In the case of an accelerated idioventricular rhythm, this is going to be the same as an idioventricular rhythm that has a rate of more than 40 beats per minute. This rhythm emerges only when the SA node and AV nodes fail to initiate an impulse. The Purkinje fibers are capable of generating that intrinsic rate of 20 to 40 beats per minute. Because this last pacemaker is associated in the ventricles, the QRS complex appears wide and bizarre with this slow rate. If the rate is between 40 and 100 beats per minute, this rhythm is called an accelerated idioventricular rhythm. And asystole. This would be, generally speaking, a lack of a rhythm, a cessation of electrical activity. It's characterized by that flat baseline is seen without any evidence of P waves, QRS, or T wave forms, and only the slightest variation off of the isoelectric line. A pulse is absent, and there is no cardiac output. This is cardiac arrest. In the case of an AV block, which is also known as a heart block, this refers to an inability of the AV node to conduct sinus impulses to the ventricles in a normal manner. AV blocks can cause a delay in conduction from the SA node through the AV node, or completely block conduction intermittently or continuously. The AV blocks may arise from normal aging of the conduction system, or could be caused by damage to the conduction system, such as ischemic heart disease. Other causes could be infections, myocardial infarctions, coronary artery disease, enhanced vagal tone, or the effects of drugs such as digoxin toxicity. We're going to discuss four types of block. There's going to be a first degree block, a second degree block type 1, also called a Winky block, a second degree block type 2, or a Mobitz type 2, or a third degree block, or a complete block. In the case of a first degree AV block, this describes a consistent delayed conduction through the AV node, and it's represented in the ECG by a prolonged PR interval greater than 0.2 seconds, though it does have the same PR interval for each beat. Next up would be a Mobitz type 1, or a Winky block, which is also a lot of fun to say. This second degree type 1 is represented on the ECG by a progressively lengthening PR interval until eventually a QRS complex is dropped. The AV node progressively delays conduction in the ventricles, resulting in this longer and longer interval. Not to be confused with a second degree AV block type 2, or a Mobitz 2. And this is the more critical type of heart block that requires early recognition and intervention. This conduction abnormality occurs below the AV node, either in the bundle of His or in the bundle branches. A P wave is generated, but it's not conducted to the ventricles for one or more beats. There is no progressive lengthening of the PR interval, which remains the same throughout, with the exception of the dropped beats. A second degree type 2 is often associated with a bundle branch block and a corresponding widening QRS complex. However, narrow QRS complexes may be observed. And finally, we have a third degree block, often called a complete heart block, because there's no atrial impulses that are conducted through that AV node to the ventricles. Because of this, the block it can occur at any level of the AV node, the bundle of His, or the bundle branches. In a complete block, the atria and ventricles beat independently of each other. Because that AV node is completely blocked, there's no corresponding P wave to QRS. Both are beating independently, which will give you that sporadic PR intervals with P waves at random rhythm, while the QRS is at a different rhythm measured without it, completely unrelated. In this complete heart block, the patient may need a pacemaker. We also want to monitor their hemodynamic status closely, depending on how symptomatic the patient is with this rhythm. A patient states that he isn't feeling well. You assess diaphoresis, tachypnea, and chest discomfort. The nurse looks at the monitor and assesses second degree heart block, or a Mobit 2. What are your priority interventions? That second degree block is often associated with a bundle branch block and a corresponding widening QRS complex. It can progress to more clinically significant third degree block and could cause the patient to be symptomatic. This patient is going to require emergent treatment with transcutaneous or transvenous pacing, followed by insertion of a permanent pacemaker if the underlying cause cannot be resolved. Speaking of pacing, a pacemaker is often implanted to treat symptomatic bradycardia, which may occur from a number of different pathophysiologic conditions. These include second degree, third degree blocks, or sick sinus syndrome. The need for a pacemaker may be temporary, such as after an acute MI or surgery, or it could even be permanent. Battery operated external pulse generators are also used to provide electrical energy for temporary emergent situations. For temporary pacemakers, transcutaneous electrical stimulation is delivered through the skin via external electrode pads connected to an external pacemaker. In the case of transvenous, a pacing catheter is inserted percutaneously into the right ventricle, where it contacts the endocardium near the ventricular septum. It's connected to a small external pulse generator by electrode wires. Note the electrical ports on the pacing catheter. They're connected to the pulse generator, whereupon pacing thresholds are set for each specific patient. When setting a pacemaker, there's going to be many terms, such as setting the heart rate, the mode, the electrical output measured in milliamperes, sensitivity, the sense pace indicator, and the AV interval. The rate control determines the number of impulses delivered per minute to the atrium, the ventricle, or both. The rate is set to produce effective cardiac output and reduce symptoms. In the case of electrical output, again, it's measured in milliamperes, in which it varies depending on the type of pacing as well as what the patient is responding to. For sensitivity, this is the ability of the pacemaker to recognize the body's intrinsic or native electrical activity. It's measured in millivolts. Some temporary pacemakers have a sense pace indicator. When the generator delivers a pace beat, the pace light comes on. If that generator detects the patient's own beat, the sense indicator should light. Temporary pacemakers have dials or keypads for adjusting this sensitivity. Here we just have a visual example of how setting these pacemakers would work. And here is another diagram representing the permanent pacemakers that may be used to stimulate the atrium, ventricles. Atrial pacing is used to mimic normal conduction from the SA node and to produce an atrial contraction, thus providing that atrial kick. Ventricular pacing stimulates just ventricular depolarization, and is commonly used in emergent situations or when pacing is required infrequently. Other option would be dual chamber pacing that allows for stimulation of both atria and ventricles as needed to synchronize the chambers and mimic a normal cardiac cycle. Pacemaker rhythms are usually easy to identify on the cardiac monitor or rhythm strip. The electrical stimulation is noted by an electrical artifact called the pacemaker spike. If the atrium is paced, the spike appears before that P wave. If the ventricle is paced, the spike appears before the QRS complex. If both the atrium and ventricle are placed, the spikes are noted before both the P waves and the QRS complex. And here we have a ventricular pace rhythm. Notice that spike of the pacemaker immediately before each QRS complex. And this would be an example of a dual chamber paced rhythm. Notice that spike occurring before the P wave and then a pacemaker spike that occurs before the QRS. Some complications would be a failure to pace, failure to capture, or failure to sense. In a failure to pace, this is a fire occurs when the pacemaker fails to initiate an electrical stimulus when it should fire. The problem is noted by an absence of pacer spikes on the rhythm strip. Causes of failure to pace include battery or the pulse generator failure, fracture or displacement of a pacemaker wire, or loose connections. Failure to capture is when the pacemaker generates an electrical impulse and no depolarization is noted. It's described as failure to capture. On an ECG, a pacer spike is noted, but it's not followed by a P wave for atrial or QRS for ventricular. Common causes of failure to capture include the output is set too low, or displacement of the pacing lead wire from the myocardium. Other causes could include battery failure, fracture of the pacemaker wire, or increased pacing threshold as a result of medication or electrolyte imbalances. Adjusting the output if the patient has a temporary pacemaker And placing the patient on his or her left side are nursing interventions to help treat this failure to capture. Turning the patient onto the left side facilitates contact to that transvenous pacing wire with the endocardium and septum. And finally, in a failure to sense, when the pacemaker does not sense the patient's own cardiac rhythm and initiates an electrical impulse, it's called failure to sense. Failure to sense manifests as the pacemaker spikes that fall too closely to the patient's own rhythm. Other than the programmed rates, the most common cause is displacement of the pacemaker electrode wire. Turning the patient to the left side and adjusting the sensitivity are again nursing interventions when failure to sense occurs. Here we have an example of failure to pace, when the pacemaker fails to initiate an electrical stimulus when it should fire. The problem is noted by an absence of pacemaker spikes on the rhythm strip. These causes include battery or pulse generator failure, up to fracture or displacement of the pacemaker wire, or even just loose connections. And here we have an example of a failure to capture. You'll notice those pacemaker spikes there on the right that are not not followed by a corresponding contraction. And here we have a failure to sense. This is when the pacemaker does not sense the patient's own cardiac rhythm and tries to initiate an electrical impulse. In the case of the implantable cardioverter defibrillators, these have an additional electrode wire placed throughout the coronary sinus into the left ventricle. These additional pacing wires are in the atria and the ventricle, pacing both ventricles simultaneously, improving heart function in a certain number of heart failure patients. Synchronous depolarization of both ventricles improves cardiac output as well as ejection fraction. And just wrapping up, as a review on reading these rhythms, you want to do it in a systematic manner, beginning with, is the rhythm regular? What is the heart rate? Assessing the P waves, the PR interval, looking at those QRS complexes, and finally the T waves. It's going to take practice, but at the same time, the more and more you do it, the easier this is going to get. Don't let it be an overwhelming thing. Just look at it one piece at a time. Look at, is the rhythm regular? What is our heart rate? Looking at those P waves and PR interval, that's going to tell you everything you need to know about the atrial status of the patient. Look at the QRS complexes. Are they wide? Are they narrow? That's going to give you a good clue as to where that signal is originating. EKG is an essential competency, especially if you're on a cardiac floor working in critical care. Being able to read and interpret that ECG is going to be a critical skill. That 12 lead allows different views of the patient's electrical activity, and that rhythm interpretation is going to be best achieved with a systematic approach, going slow, and just taking it one step at a time. Now, don't let it be overwhelming. What you've got right here is everything you need basics to begin and take that next step and eventually get your own ACLS certification. But anyway, that's all we got for this chapter. I'll see you in the next slides.